So, our next presenter is Tamil Kendall. Tamil is a Canadian Institutes of Health Research postdoctoral fellow with the Women and Health Initiative at the Harvard School of Public Health and senior HIV advisor for the feminist Mexican non-governmental organization Balance. Tamil has worked as a researcher and advocate with women living with HIV in Latin America for more than a decade. Her current research, including the collaboration with the Mesoamerican Coalition for the Reproductive Rights of Women with HIV, which she's speaking about today, is oriented towards creating the conditions necessary for the effective exercise of sexual and reproductive rights by women living with HIV. Tamil.
Thank you very much for the invitation to present this work on behalf of the Mesoamerican Coalition for the Reproductive Rights of Women with HIV and my colleagues Claire Albert and Gabriela Garcia. So I'm really grateful to Alejandra for pointing out some of the context in the 4 countries that I'm talking about, Mexico, El Salvador, Honduras, and Nicaragua. They all have concentrated HIV epidemics, less than 1% general population prevalence, and over 5% in certain key or most vulnerable populations, which universally are men who have sex with other men and male sex workers, trans women where studies have been done, and depending on the countries, female sex workers and injection drug users. In these countries, there are an estimated 60,000 women living with HIV, and their proportion of the people living with HIV in the countries ranges from 22% in Mexico to 41% in Honduras. So just a little bit about the international human rights framework and commitments, and then the science. We know that there are international commitments to achieve universal access to reproductive health services by 2015, and these are enshrined both in the 5B target of the Millennium Development Goals, as well as in the International Conference on Population and Development that turns 20 this year. And obviously, these are universal commitments, and people living with HIV should not be excluded from them. Furthermore, the science is advancing quickly. We know that undetectable viral load reduces sexual transmission, opening up possibilities for safer conception in serodiscordant partners, and that other forms of medical management, including timed unprotected intercourse, home-based insemination, are feasible in middle and low-income countries. Also, vertical HIV transmission is extremely effective. We've been talking about 1% here at this conference, and data from the UK shows that we can get below that at the population level. And a full range of contraceptive options are appropriate for women living with HIV, though there may be specific medical concerns around disease stage and antiretroviral treatment. So really, there's no reason, based on the human rights framework or the science, that women living with HIV can't exercise their reproductive rights. So the data that I'm going to share with you about the situation in Latin America is from a participatory process where feminist lawyers and women leaders living with HIV developed an instrument to document reproductive rights violations. And between 2012 and 2013, the 3 major networks that involve women living with HIV in the region, the International Community of Women Living with HIV, Red Lac Trans, and Red Track Sex, as well as 25 other non-governmental organizations, did this data collection. In total, we collected 337 questionnaires. In this analysis, I'm excluding the trans women, so only 285 women could possibly be included. And it has limitations in that it was a convenient sample where women were sampled through the personal and professional networks of the peer researchers, but it also has strengths in terms of the geographic scope across 4 countries and more than 37 political districts, so that's states or departments inside the countries. And I'm presenting both a qualitative and a quantitative analysis. So who were these women? We can see here that at the time of the survey, most were of reproductive age, that similar to what Alejandra showed, that a little more than half of the women had primary education or less. Almost all had children. A little less than half were in stable unions. We had good representation both of Indigenous women and women of African descent. 87% of the women were on treatment, and all were in contact with health services. Now, about half of the women, based on not having a cement or tile floor in their home, could be considered poor, with 18% of those women being very poor, in that they didn't have any other source other than firewood for cooking or for heat in their homes, and another 18% being relatively better off in that they had home internet. 28% of the women had had a pregnancy since their HIV diagnosis, and almost 17% said that they planned to become pregnant in the future. So we can see that this group of women both need access to information about pregnancy prevention and safer conception and safer pregnancy. However, when we asked women about this, really the rates were very low. So I was very surprised by this, that these women, all of whom were in care, only slightly more than half of them said that they had received information about prevention of vertical HIV transmission. Similarly, only 43% knew about pregnancy with minimum risk for themselves or their partners or child, and only a third had heard anything about reduced risk with antiretroviral therapy to a serodiscordant partner. And then in terms of the specific medical interventions for safer conception, which included not only undetectable viral load, pre-exposure prophylaxis, insemination, but also changing the antiretroviral regimen before conception, because eliminating efavirenz is still the normative guideline in all of these countries. Only a fifth of women had heard anything about any one of these. In the multivariate analysis, where we looked at women's fertility history, social and economic characteristics, what we see is that across the board, pretty much women with children were less likely to have received this information, and in the case of safer conception, the specific interventions, they were significantly less likely to have done so. And that also, in the case of pregnancy with a serodiscordant partner, women who were in stable relationships were less likely to report having received that information. It's quite interesting that both Indigenous and women of African descent were statistically more likely to report having received information to support safer pregnancy. Now, in terms of pregnancy prevention, only a quarter of the women had received information about contraceptives additional to the condom, so dual protection, in HIV care. 15%, the possibility of drug interactions. Well, nearly 90% of these women were taking antiretroviral therapy, and only 10% about their health status and ability to use the IUD. And the consequences for women are represented here by this quote from a woman from Honduras who said, "I got pregnant because they said that a woman with HIV can't use contraceptives other than a condom." And this, unfortunately, remains a very common situation in the region. In the multivariate analysis, here we see that it comes a little closer, though in some cases, women with children are still less likely than other women to receive information about contraception, and it's notable that married and common law women are less likely across the board to receive this information than women who are not in stable relationships. Do I want to say anything else? No, that's fine. So we can clearly see here that the right of women living with HIV to the information that can allow them to make informed sexual and reproductive choices is not being met within HIV services in the region. And it really draws attention that in some cases, women in stable unions and women with children, who we might assume are the women who most need this information, are those that are not receiving it. It's also worthy of note that women of indigenous and African descent were more likely to report receiving information to support safer conception, and this is something that merits additional research. And I would say that overall, this is the perspectives and experiences of women living with HIV, and there's a need to do more of this work with providers to understand what are the knowledge gaps and attitudes that are driving this poor practice in terms of counseling around sexual and reproductive health in HIV services. So I'd recommend that clearly women's reproductive desires and fertility intentions need to be regularly assessed inside HIV care, and that for this region and others, though sub-Saharan Africa has certainly made greater strides on this topic than Latin America has, there's a need to offer other contraceptives within HIV care and not be ignoring women's pregnancy prevention needs and expecting them to seek out services, disclose their HIV status to providers who don't know about HIV, who probably will not consult the World Health Organization medical criteria on women living with HIV for their recommendations. In our concentrated epidemics, this is something that should be dealt with as part of HIV care. And to do this, healthcare providers require technical training, particularly on what we're learning about safer conception and conception in serodiscordant partners. So there's new research from the United States, for example, that shows that HIV care providers who know about the risk of transmission sexual transmission between serodiscordant partners are more likely to counsel their patients who want to conceive about timed unprotected intercourse. So we need to make sure that providers around the world have access to this information. And then there will also be a need to have a component of human rights training so that care providers can actually support women in their exercise of their reproductive rights. I'd like to thank and acknowledge all of the organizations that are part of the Mesoamerican Coalition for the Reproductive Rights of Women with HIV, and also the donors who have supported me and this research. Thanks very much.
Thank you very much, Tamil. And I've seen people walking in after we started. We said if you have questions for Dr. Tamil or any other, please write them on a piece of paper and give them to the ladies in the blue t-shirts. Then we will take the questions at the end.